Today's presentation would be on uh, the surgical anatomy. We'll talk about the endoscopic craniofacial resection. We'll see what evidences we have to support it. Last time there were questions regarding margins, so we'll talk about that. We've already covered regarding adjuvant treatment and those aspects in the previous talk itself, so I'll not be dwelling on that. And I'll be showing you a couple of videos. One would be an endoscopic endonasal resection, and the other one will be a combined combined craniofacial resection. So before we start, it's important to know the relevant surgical anatomy. It will just be for most of us a refresher of the anatomy of the skull base. So because most of us are familiar with it, so but then I thought it will be essential to know this as we go ahead in this topic. So we all are aware that skull base anatomy is complex. It forms the base of the cranial cavity, and there are a lot of important structures housed in the skull base. And that is why it is very important to know what structures are located where, because as we deal with the pathology that you're operating on, you need to know what structures you'll encounter to avoid damage to the structures, because it gives rise to a lot of morbidity and at times mortality too. So it is very essential that it's prudent that we know the anatomy pretty well. And also these structures are not amenable for an obvious clinical examination, like examination of the oral cavity or the head and neck. So these are structures within a cavity, housed within a cavity, and so it's difficult. So it's mostly a radiological assessment along with the clinical examination that will give you an idea. So just to begin with, anterior skull base, the boundary, as you see the dotted line here, that forms the anterior skull base. The posterior wall of the frontal sinus forms the anterior boundary. The posterior boundary is formed by the lesser wing of the sphenoid, and the floor is formed medially by the cribriform plate and laterally by the orbital plate. So this area is the anterior skull base, and that's our focus for today's discussion as well. Now, this is an important picture of a cadaver, which tells you what is the limitation when you are planning an endoscopic resection. You have this line which is drawn along the medial wall of the orbit and going towards your optic canal. Now, you see that's the orbit there, and this is the optic nerve, and that's the carotid vessel. So this yellow line which goes along and this is the anterior clinoid process. So this yellow line shows the lateral extent. If there is any pathology located in this area, is what will be amenable to an endoscopic resection. This is the olfactory bulb. This is the cribriform plate. This is the the cribriform plate and the planum, and this is the sella. So the structure, any pathology which is there in this area is accessible endoscopically. And if you just so for when we're beginning with doing an endoscopic craniofacial resection for any malignancy, we should start off with any pathology located in this area, and then you may, as you gain experience, go till the red line, but then that would not be ideal that should not be your first case to begin with, So these are the structures that you need to know. You see that's the roof that is removed, and you see the ethmoidal arteries and all coming in the nasal cavity. So just keep in mind this yellow line here that is drawn from the medial border of the orbit posteriorly going towards the optic canal on either side. So that's the area which tells you that these structures will be amenable for your endoscopic resection. Keep this in mind as we would further discuss as to what are the indications and contraindications. Again, the same, this is the bone depicting the anterior skull base, the cribriform, cribriform plate here. You can see the minute pores out here through which the olfactory fibrils go in, and you'll have the olfactory bulb here and the crista galli. So again, reiterating the boundary, the posterior wall of the frontal sinus, the lesser wing of the sphenoid here, that's the clinoid process, and this and this is the orbital loop. Now this is the planum. Now this again is an important thing to understand as we go ahead. Discussing about the indications. Now here you see this is the planum, and that's the dura that is still attached in the specimen. Now, when the tumor goes posteriorly towards the planum here, this dura is thin and is dense, and it is more adherent to the underlying bone. Now, that again is an important factor when we decide about endoscopic versus open. That I'll again tell you when we discuss about the resectability aspect. Because if you resect this in any part of the dura, if it is going posteriorly, if you have to resect this dura far more posteriorly, the dura will be very thin, number one, and then you'll not get, and it'll be very, and it you'll not get enough dura to suture your flap to, that is your pericranial flap, whenever if you're going to use. So your limit should be when the tumor is somewhere just at the uh, edge of the planum. Anything posteriorly, because you'll have to take some margin as well. You cannot go way too posteriorly and deal with it endoscopically, in which case you'll have to do a combined approach, endocraniofacial resection. This is another important point. This is the same view showing it is in a coronal section here. This is the anterior part. That's the cerebrum that is seen. That's the carotid artery with the branches. And you see that is the optic chiasma, and here you see this is the yellow line depicting the same, that is from the medial wall of the orbit going posteriorly towards the optic canal, right? This is the same again endoscopic view. So any tumor that is present in this aspect here should be amenable for an endoscopic resection. This we have already seen. Now I'll just deal with the structures as you would encounter them while doing the endoscopic resection, and talk about the relevant surgical anatomy aspect. We all know about the attachment of the middle turbinate and all of that, but I'll just tell you the important factors that you need to keep in mind while you're doing an endoscopic resection. So, uh, so we essentially will be focusing on the transcribiform approach for this lecture. Of course, as for the corridor approach, you have the other, the transcellular, the transclivis, the transodontoid, the transplanum approaches. So mostly the approach will be the same for the transfrontal, the transcribiform, and the transplanum. For the transcellular and the clivus, it's slightly different. You don't have to do a middle turbinectomy all the time. But so the focus here will be on the transcribiform approach. So here you would be doing the anterior to posterior approach, the classic mesial Kingler's technique that you would be following. So one of the steps while doing this transcribiform approach would be to do a middle turbinectomy. So while doing the middle turbinectomy, we are all aware that, as you see in this picture, the middle turbinate superiorly is attached to the cribiform plate. So while doing the turbinectomy, you should not go flush with the attachment, in which case you will encounter a series of leak up front, and makes your surgery that much more difficult. So that's why it's essential to to do the turbinectomy at the axilla to avoid this, so that you can go ahead with your surgery uninterrupted. That is one point that you need to understand. The other thing is, in relation to the same, we all know what the Keros classification is, and just one thing that we need to keep in mind is what type of Keros classification is more common. We all know the type 3 Keros classification is more prone for injury during the endoscopic sinus surgery. And this study, which was published in the Indian Journal of Radiology, Radiological Imaging, in 2018 from Kerala, one of the institutes in Kerala, where they studied the NCCT PNS of over 1,200 patients, and they found that in close to 75% of the patients, the commonest type was Keros 2, so which is not a high at-risk type of attachment for injury during surgery, similar with type 1. So type 3 is seen in close to only 8% of the patients, and its prevalence is low, but when it is seen more on the right side, and that too in men. Just one point that you can just keep in mind at times, but many times in the anterior skull base lesions, the skull base is filled with tumor and it's eroding the skull base. So this may not be of much significance in that situation, but it's better to know it when it's not the case. Now, once we've done a turbinectomy, we need to do an anterior and posterior ethmoidectomies. So as we proceed to do that, we need to do an uncinectomy, the antrostomy, and then the ethmoidectomy. So this is all possible on the side where there is no disease, when you have to do a bilateral approach to do a endoscopic craniofacial resection. I'll tell you why it is important. This is the classical description of the procedure. There can be modifications to this. I'll not go into the modifications. I'll tell you what's the classical steps, so that that can be modified based on the type of disease that you're dealing with. So, and when the tumor is present, then it's a different thing. But I'll tell you what are the steps as such in the subsequent slides. But just keep that aside and just think that when you're doing a transcriptiform approach, first you'll do a middle turbinectomy, then you'll do an uncinectomy, antrostomy, and anterior posterior ethmoidectomy. So we all know we have to proceed in an inferomedial direction to go towards the sphenoid. So as we do that, we need to know, we need to be cognizant of these anatomical variations of these ethmoid air cells. One is the HALA cells you need to be aware of. The most important thing that you need to be aware of is the Onodi cells, which if you are not aware of, which is filled with secretion or some hypertrophic mucosa, and then overzealous attempt to clear the disease, you might go and damage the optic nerve. And the case that we'll be seeing the video subsequently, also that case also has an Onodi cell, which we'll be seeing that subsequently. The other thing is the supraorbital cell here, and if the disease is going here into the supraorbital cells, and if it's going far too laterally, that is again one of the contraindications for a completely endoscopic clearance. It cannot be totally endoscopically cleared. Now, just imagine if the disease is going all the way up till this lateral edge of your supraorbital cell or going into the frontal sinus. You essentially, with your endoscopic instruments, it's going to be really difficult. So you may have to combine it with some amount of open procedure along with your endoscopic clearance, especially if it is a malignancy. Benign lesion is a different thing that I'm talking about. Of course, once you do the anterior and posterior sphenoidotomy, then anterior and posterior ethmoidectomy, you go open up the sphenoid sinus, and that is doing a sphenoidotomy. So superiorly, we saw the middle turbinate attaches to the cribriform plate. Here, laterally, it attaches to the lamina paprica in a zigzag fashion. Once you do an uncinectomy, do the anterior posterior ethmoidectomy, and then you come into the sphenoethmoidal recess, and you look into the ostia and then widen this. So this is all important because the exposure of all these structures is important to do a craniofacial resection. So if you're opening up the sphenoid for any reason, you need to know what is the type of pneumatization, and this is very essential for a transcellular approach. So we all know that the sphenoid is pneumatization is basically three types: the cella, which is the most commonest, the pre-cella, as you see here, and the concyle. Concyle is the most difficult one. Pre-cella, yes, of course, if you're doing a transcellular approach, and the cella would not pose you that much of a problem. So this is again in the study, which again tells you essentially that the cellular pneumatization is the most commonest in different races, the Caucasian, the East Asian, and in one of the Indian studies as well. So once you open up the sphenoid, when there is disease in the sphenoid sinus, there is not. It depends on whether it's eroding the walls of the sphenoid sinus. So if that would, when it is eroding the walls, we have already discussed in the previous talk that the lateral and superior erosion of the wall is not is a contraindication for surgery. But having said that, if there is disease coming up to the anterior wall of the sphenoid, when you go beyond that, you have to go a compartment ahead, which will be so in that case, you open up the sphenoid, then you will see the structures that you see is the optic nerve, the carotid artery here, and the opticocarotic recess. This is the clivus here. So these are the structures that you need to expose, and of course, this exposure is required to do a transcellular approach, that is for the pituitary surgery. So we have done the middle turbinectomy, anterior posterior ethmoidectomy, sphenoidotomy. So you have the posterior boundary there. Next, you come on to the frontal recess. That is again important. So we all know frontal recess is kind of a difficult part of the surgery because it's difficult to open it because of these variations, the frontal air cells that you can encounter, and also it's the anterior ethmoidal artery forming the posterior boundary. So when there is a lot of tumor there, it may not be very much obviously visible, but you need to make an effort to look at the anterior ethmoidal artery as well. Otherwise, it may give rise to problems subsequently. So let's see what are the types of frontal air cells. We know the type 1 single cell not extending into the frontal sinus. That's the most commonest, thankfully. The type 2, two or more cells sometimes extending into the frontal sinus, and type 3, single cell extending into the frontal sinus, and then type 4 is an isolated cell located within the frontal sinus, which is the rarest. You can just see an example of that here. So these are the frontal type of frontal SLs, which if there is disease, if in most of the times in malignant cases, you will not be able to appreciate because there'll be disease filling up the entire cribriform area and the frontal recess area. So you really will not be able to make this out. But then it's essential to know these variations because it depends on if both the frontal recesses are involved in disease, it's okay. But if it is not, then on the normal side, when you go to do the craniofacial resection, you need to be aware of this so that you have to expose the frontal recess to do the modified Lothrop's, the draft 3 kind of a procedure. So to open up these air cells, the frontal sinus technique is to open up the eggshell type of thing, go posteriorly towards the air cell and remove the bony structure of the air cell. Go from keep your instrument posteriorly and come anteriorly. It should be posterior to anterior and not otherwise, in which case it may lead to damage. You can see the anterior ethmoidal artery forming the posterior boundary. So once you open this air cell is when you can gain access to the frontal sinus. So it's essential to be aware of all of this. I'm sure most of you, all of you will be knowing this, just to reiterate the fact. And the other technique which I personally find very useful is the axillary flap technique, which most of you might be aware of. Just that the mucosa, to elevate the mucosa around the attachment to the maxillary sinus and drill the bone, and we straight hit the frontal recess. So that is one technique where you can adopt. So this all depends on the case-to-case basis as to where exactly the malignancy is there. If there is disease occupying the frontal recess, as you keep removing the disease, you will be going into the frontal sinus. The ethmoidal arteries is very important. You need to know the anterior and the posterior ethmoidal artery that comes from it's a branch from the ophthalmic artery. So it comes from lateral to medial, and it goes over the roof of the nasal cavity. So we need to cauterize this if you have to drill this cribriform area. So just imagine there's disease here, so you have to remove the disease. So if you have to remove this bone, you need to cauterize this. Otherwise, this artery might retract into the orbit. So it's very essential that you identify these arteries and cauterize them to prevent that from happening. That is important. That is why it is important to know this. And this is another fact that the ethmoidal artery, it may lie within a bony tunnel. So most of the time, and sometimes partially within a bony tunnel, sometimes it may be hanging down in a mesentery. So fortunately, it is the type B which is more common than the rest, the other two. But then we need to be aware of these facts, and these are the studies on cadaver which says at which distance you would encounter them. Of course, while doing surgery, you cannot actually measure that, and becomes difficult, but you can just know that. So this is the draft 3, which is the picture of on a cadaver, where once you have the posterior. So when you're doing an endoscopic resection, you need to have this vision, because most of the time the malignancy is originating from one particular area. So you need to go all around it and remove that base, the area from where it is originating, to remove that with a margin and get the other margins cleared. So that is what is important. So the most important thing here is to get this. So that is why we are doing all these ethmoidectomies bilaterally and all that. So and of course the septectomy. So anterior margin is the posterior wall of the frontal sinus. You have the lamina papyracea on either side, posterior the planum. So you have to expose all of this before coming into the cribriform plate area. Without this exposure, we will not be able to get the resection, and most importantly, you'll not be able to reconstruct the defect. So that is why it is essential to have this exposure. And here you see the ethmoidal arteries, those needs to be cauterized well. Again, the same point that is being made. So you need to get this properly so that you can resect the lesion and also reconstruct the defect. So one of the flaps that is a workhorse flap for skull-based surgery is the nasoseptal flap, the Haddad flap. That's actually the Haddad Basagastrier flap. Unfortunately, it's more famously known as the Haddad flap than the second name. But then we need to know that the sphenoparietal artery, as it comes out, gives out the septal arteries, and it divides into the superior and inferior branch. So the superior branch comes just at the level of the lower level at the the sphenoid ostium. So when we give the incision for the Hadad flap, we have to be slightly above the level of the ostium to have the arterial supply intact. And of course, we all know the Hadad flap, the septal flap. We can have an extended Hadad flap, including the nasal mucosa and part of the inferior meatus as well. So these are some of the things that will help us design the flap better. I'll not be dealing with the transpterygoid approach, but just to have a word about it. So this is essentially needed for any nasopharyngeal lesion or any lesion that is there in the infratemporal fossa, that and pterygopalatine fossa, that can be accessed. You can see the various areas that you can access it: the infratemporal fossa here, and the pterygopalatine fossa, and the nasopharyngeal area. So any pathology here can be accessed. Uh, so that's about it. I will not dwell with this more other than this, because we are mostly dealing with the transcribriform plate. So mostly, if we talk about malignancy, the transpterygoid approach would be most commonly coming in handy in an adenoid cystic carcinoma, when the disease goes, when there is a perineural spread along the nerves going into the cavernous sinus, in which case this will be handy. But otherwise, for a nasopharyngeal carcinoma, the first line of treatment is non-surgical, and for a recurrence, of course, we know nasopharyngectomy can be done endoscopically. And the other infratemporal fossal lesions mostly would be benign, like schwannomas or anything of that sort, just to give you an example. So to conclude this section of the relevant surgical anatomy, I would just conclude by saying that this is essential to be aware of the anterior skull base anatomy and its variation for a safe surgery. Now, from here on, we will be focusing on craniofacial resections. So we'll look at the evidence for the skull base resection, the concept of margins, and then we will look at the videos pertaining to that. So craniofacial resection, the first open craniofacial resection was described in 1963 by Ketchman, and ever since it has been a gold standard for many of these skull-based malignancies. And CFR has revolutionized the management of anterior skull-based malignancies. And this was also backed by improvements in reconstruction techniques, both open as well as endoscopic. One of them is the Hadad flap that we have just discussed, and delivery of adjuvant therapy. By saying that, I mean the technology in terms of the delivering adjuvant treatment using IMRT. We have discussed previously itself that all skull-based tumors, preferably all head and neck, but definitely for all skull-based tumors, IMRT will be a better treatment modality to deliver the adjuvant, so that the adjacent crucial structures can be spared. And also with the improvements in the chemotherapy agents as well, quite a lot of options that are available nowadays. And open CFR still has specific indications for sure, but it's associated with considerable morbidities. That's why people have slowly switched over to endoscopic CFR whenever it can be done safely, to achieve, by achieving a negative margin and reconstructing the defect adequately with acceptable morbidities. And when it is not possible to have this, open CFR is definitely the option of treatment. Now, endoscopic resections for malignant skull-based tumors, it started off in the late 1990s, somewhere around 1998, 1999, and early 2000s, and there were a lot of publications that came up subsequently. The endoscopic approaches were applied to resection of sinonasal malignancies afterwards. We all know in 86, the mesenchymal technique was popularized. Then Stamberger popularized this. The pituitary surgeries became more of endoscopic procedures became to be favored more than other techniques that were there till then. And till about the late 1990s, malignancies using endoscopic surgeries were not favored because of the problem of the piecemeal resection of the tumor. Oncologically, we have always been taught that en bloc resection is the way to go, and that's why people were hesitant. But slowly, there were a lot of people slowly started using them and started getting good results. And as you can see in this graph, the number of publications using endoscopic techniques have just only skyrocketed ever since that time. And beyond 2015, you can imagine the number of publications that have come up. So these are the various skull base approaches that we have already discussed. The corridors, because the concept of endoscopic approach is based on corridors. Now we're going to talk about only these corridors, essentially limiting ourselves to the transcribiform corridor here. Now, previously, the endoscopic craniofacial resection has been pretty much accepted as a standard of care for skull-based malignancies. Whenever it can be safely resected with negative margin, and the defect can be reconstructed, minimizing the complications. So that has been fairly well accepted. But the key here is to achieve a negative margin. So because many studies have shown that a positive margin is detrimental for the success of the treatment. So this was a systematic review that was published in 2019, which compares endoscopic craniofacial resection versus open craniofacial resections, and they have shown survival is comparable between the procedures. Only thing that made a difference was the grade of the tumor rather than the stage. So we've all seen that grade of the tumor, irrespective of the approaches as well, higher grade lesions did well despite the treatments, and the lower grade tumors did better. That is obvious, that we all know that. It didn't make a difference with the stage. So mostly the open techniques were done for advanced stage lesions, obviously. But endoscopic CFR and open CFR yielded comparable survival. Until date, there's no randomized trial to compare this. I'm not sure. I don't think we will ever get a randomized controlled study comparing these two things. So the best we have is this, and I'm sure it is now established beyond considerable, certainty that endoscopic CFR is oncologically safe. The other thing is, how is endoscopic surgery better than open CFR when it can be safely done? Is it improves the quality of life of the patient, which is very important. For any treatment related to oncology, there are two things that make a difference. One is survival, and the other one is quality of life. So if there is a new treatment that is being evaluated, it should influence these two domains. It should improve survival, at the same time not be negatively impact the quality of life. If that is the case, that treatment is a big success. So as far as so we have seen previously, the survival is not hampered, and here we see that the quality of life is better in open in endoscopic CFR than in open CFR. We can see that, of course, though the sample size is better, the quality of life in the anterior skull base surgery questionnaire shows that the quality of life is better using endoscopic surgery. Now, let's come to the indications. Which approaches to choose when? Now, here, by meaning which approach, meaning whether endoscopic or open is what I'm talking about. Not the corridors that I'm not mentioning to the corridors here, right? So this is one nice flowchart that I found, and it's very useful. Now, if there is any skin involvement, if there is involvement of the nasal bone, if the frontal bone is involved, and if the orbital soft tissue is involved, if it is yes for any of those, not just all, any of those, then you need to ask this next question, whether there is any intracranial involvement. If yes, it's, of course, if it is any of these, it's an open approach, no doubt. And based on the intracranial approach, intracranial extension, you decide whether it's a transfacial or a transfacial with a craniotomy. That's all. So in the presence of facial skin involvement, in the presence of nasal bone involvement, frontal bone involvement, orbital soft tissue, you would not do an open approach. You will not do a endoscopic approach. It's fairly simple and straightforward. When none of these are involved, then again you ask the question whether there's an intracranial involvement present or not. If there is no intracranial extension, there is obviously endoscopic would be the approach of choice. It would be the modality of choice. If there is intracranial extension, you need to look at the investigation whether there is involvement lateral to the medial orbital wall. If you remember the first few slides I just showed, I'll show you in the subsequent slides as well, whether there's involvement lateral to the medial orbital wall. If that is the case, then it cannot be totally endoscopic. It can be a combined approach but it cannot be a totally endoscopic, because getting the lateral clearance beyond this medial orbital wall will be difficult. Now here we're talking about malignancy. You need to get a negative margin and reconstruct it to avoid a complication. The most important complication that you're worried about, a CSF leak and a pneumocephalus, which you don't want. So in that case, you would do a combined approach. It's not going to be totally endoscopic. If it's a no for any of this, then you could still consider endoscopic. So it's a fairly simple, straightforward flow chart based on which you can decide as to what will be the approach. So just to recap again, when there is involvement of the facial skin, nasal bone, frontal bone, or orbital soft tissue, you cannot do an endoscopic. It has to be an open procedure, right? If none of these are involved, then you have to ask whether there is any intracranial involvement. If there is an intracranial involvement, you have to see whether the intracranial involvement is going lateral to the medial orbital wall, in which case it cannot be a purely endoscopic approach. It will be a combined approach. Now, just to tell you, show you an example here. Now, look at this. So this is the medial wall. It's going way beyond laterally. Now, you have to get, for a margin, you have to go laterally for the dura if you have to resect the dura. Now, this will not be upfront resectable for sure. Now, even if you give NACT and reduce it, it's going way too laterally. So in which case, you cannot do this endoscopically. You have to do it in a combined approach. This picture I've just kept to show that the disease going posteriorly or involving the planum going towards the cellar. This is not a surgical candidate at all. This patient has to be, and it's going to the nasopharynx. This patient has to be managed non-surgically, right? So just to make those points, I just put these pictures. Now, let's see the important steps of endoscopic CFR. That is the transcribriform approach. Now, first thing is to correct access issues. That is, if there's any deviated septum and all that, that needs to be corrected, and so that you have adequate access to go in. Then the other thing is tumor debulking, and this can be done with a microdebrider, and but then we should spare the normal mucosa in the vicinity, because that will help to achieve that negative margins once you have removed the disease, and also it can prevent implantation to a large extent. And also studies have shown that tumor piecemeal excision is not detrimental to survival. I'll be talking about that subsequently. And once we have done that, you can do what we have discussed already: the middle turbinectomy, maxillary antrostomy, ethmoidectomy, sphenoidotomy, and frontal sinus drill out, the modified Lothrop's, the bilateral procedure, so that we have all of this. And then a septectomy. Septectomy can be done at the beginning of it or at the end of it. And now we have opened up the entire landmarks to get the clearance, and from here on you shift to the four-handed technique, and then you do the dural resection, and then once you have the frozen section control, you achieve the negative margin, you have to reconstruct. So these are the steps of the endoscopic cradiofacial resection. Right now, last time we were just talking about the margins. So traditionally, I told you also, en bloc resection is considered the gold standard. Still it is for various other head and neck malignancies, but there have been some other areas where we have used a piecemeal excision. Now these are for selected areas only. Now you cannot say this for oral cancer. Oral cancer piecemeal excision is a big no-no, right? So largely en bloc resection is still the gold standard, but when you come to skull-based surgery, en bloc resection, even if you do an open approach, there are various studies which says that even if you do an open approach, sometimes the lesion which is posterior, it cannot be removed as one block. Sometimes you have to do a piecemeal excision only. So because of the various it's a complex anatomy and various important structures in and around it, you will not be able to do an en bloc excision even with an open, and endoscopically that's definitely not possible. So, and we can draw examples from laser microlaryngeal surgery for glottic supraglottic lesions, these Mohs microsurgery for the skin. So these are all some of the areas. These are very few areas where this has been applicable. But let me remind you again, en bloc resection is the gold standard for oncological resection per se. But these are some exceptions where studies have shown it has not made a detriment to survival. Now, this small study with 30 patients showed that with negative margins, even when you do a piecemeal excision, the most important thing is get a negative margin, because The skull-based tumor mostly is adherent to, it originates from a particular site, and then it grows down. It's mostly essentially polypoidal many a times. So you can debulk the tumor and then get a negative margin around that base from which it is attached. So you have to get a negative margin, and when you do that, there is a similar 3-year survival, irrespective of whether you're an en bloc or a piecemeal. Okay, so this gives you, and also the various series that have been published over more than 1,000 cases. It's been using the piecemeal excision most of the times, and the survival has been pretty encouraging. And achieving negative margin is crucial because there are many studies which have shown that a positive margin is detrimental to survival. But then, having said that, aiming for the conventional 5 millimeter margin in skull base is practically not achievable due to the crucial structures involved. I mean, if you want to get a 5 mm margin, means you have to remove important structures in and around it, which will only add to the morbidity and other problems in the post-op. So the concept here is to achieve complete tumor clearance, and for that, you have to go to the adjacent compartment. Like, for example, as we know, if there's lesion in the ethmoid, you clear the ethmoid, you remove the lamina papyracea and the periosteum, and you stop there. You go into the next compartment there, and that is free of tumor, then you stop right there. So if there's disease till the posterior ethmoids, you go to the sphenoid sinus. You go on one compartment ahead or cleared that. It's like that, right? So that is the concept of margins in the craniofacial resection. Moving on to the complications, various series have reported complications up to 36%. Most common complications wound related. It could be infection, dehiscence of the wound, flap necrosis. CSF related problems are most dreaded: the CSF leak, the pneumocephalus, meningitis, and hematoma. The systemic complications can be anything like MI, pulmonary embolism, the respiratory tract, urinary tract infection, metabolic complications, orbital complications like diplopia, blindness, and hematoma. And of course, the mortality has still been reported, but most of the series, it's always been less than 5%. And many of the series reported off late has been even lesser than that. So the most dreaded complication would be infection of the wound-related complications, and of course the CSF leak and the pneumocephalus and subsequent meningitis. So these are and hematoma. So these are the most common complications that you would see. And the CSF leak rates of the many series, especially single institution series, where being done with experienced hands, the CSF leak rates have been far lesser. It has been less than 10%. So to conclude, endoscopic CFR is a safe treatment option for sinus-nasal malignancies, with a caveat that when done by an expert team and for properly selected cases with all the indications and contraindications that we have discussed. The challenge with any endoscopic procedure of late, the exposure, the training to endoscopic surgery has been phenomenal. So many centers are doing endoscopic surgeries for both malignancies and benign lesions, and it's a good sign. And more people are doing endoscopic procedures. But then it all comes with a steep learning curve. And the vision with endoscopic is 2D vision. Of course, there are new gadgets that are coming with the 3D and 4D vision in the monitors with a new, the better CCD cameras. So that can help. Hemostasis, achieving hemostasis, especially in case of a malignancy, it becomes a huge challenge. So it might be a bit troublesome, but then it's just developing the technique as you keep doing the cases. And reconstruction, developing the expertise to do the reconstruction after excision of a malignant skull-based tumor is again a challenging endeavor, which can be learned, and that has to be done properly to prevent a CSF leak. Now, this is the TMH skull-based team. Of course, you all know Dr. Pratmesh Pai. He started off the skull-based clinic way back in 2002 in TMH, and a lot of TMH deals with a lot of skull-based tumors, and has been a huge variety of anterior, lateral, posterior tumors have been dealt with. With this, I would like to conclude my presentation as such, and present to you the videos.
There are a couple of questions. Do you want to take them in the meanwhile?
Yeah, you can just ask them.
First question is from Dr. Vijayadharan sir, Shivakumar. What is the maximum depth of the defect that we can use the nasoseptal flap for reconstruction?
It's not about the depth. If there is intracheal extension, The thing is, as you clear the tumor, there's a space that is developed. So the depth is not the first question here. The first question is the lateral extension, as we have already seen. When it goes medial to the lateral to the medial orbital wall, is when you don't want to do an endoscopic resection and reconstruction. So, and also in the depth, when there is huge intracranial component, then again there's a huge dead space that develops within it. So there is no question or any study which says that more than 5 mm or more than 1 centimeter, you have to take it endoscopically. I mean, you have to go case by case. And once the defect has been created at the end of your resection, you need to take a call about reconstruction. I mean, initially itself, based on imaging, you can definitely be sure as to whether you're going to do a. Oh, sorry.
Sorry, a small correction, sir. He was asking about the width of it, width of the defect.
That's what the width would be. That width is that any lesion which is going lateral to the medial orbital wall, it's better to do an open approach. There is no like 5 mm or 1 centimeter. So let me just start with this endoscopic craniofacial resection. There'll be a brief case capsule that will be just coming as we just proceed.
Just a second, sir. I request all the users again, please switch off your videos to conserve the bandwidth to show the videos which we are presenting.
Yeah. So this is a 48-year-old male patient, hypertensive, nasal obstruction. He was an olfactory neuroblastoma, as you can just see that, and the secretion in the maxillary sinus here. So it's esthesia neuroblastoma, high grade. They were saying it was, our pathologist couldn't say it was 3 or 4. They said it's anywhere between 3. It is at least 3, if not 4, and Kaddish 3 because there was an intracranial extension, no distant metastasis. So because of which, as we already discussed yesterday, we decided to give 3 cycles of NACT. Cisplatin with etoposide is the NACT of choice, and the patient had a partial response at the end of the NACT. This is the scan. There is some minimal dural enhancement that you can see. So the plan was, since now as we see here, now the lesion is just at the center here. It is not gone laterally, if you can see here. So that is very essential. If the lesion had gone laterally till here, then the reconstruction would have been questioned. So then you would have thought of doing a combined approach. So in this case, we planned to do it totally endoscopically, a transcribiform approach. So we also had a plan, because this was one-sided, so we thought we'll use the other side of the nasal septum. You can see the corner. Just we did the initial diagnostic nasal endoscopy on the opposite side where there was no disease, to just confirm before using, this is the middle, using the Haddad flap. That's the sphenoid model recess. There was no disease there, and the roof. So this is on the left side. So that is all looking normal on the left side. So this is on the right side where there's a spur there. Then there's disease. You can see here the tumor there, right? That's the tumor, and that needs to be removed. So this side, the mucosal, the septum cartilage was not eroded, so that will be the margin. So we thought we will use the Haddad flap as one of the layers for reconstruction once the defect is done. So as you all know, if you have to do that, you have to do it at the very beginning. But anyway, we started off with a middle turbinectomy because there was an access issue here going posteriorly because of that spur coming in touch with the middle turbinate. So we did a middle turbinectomy to begin with, to improve the access. And anyway, this was required as part of the craniofacial resection as well. So we as well thought we'll do it. So we gave the incision inferiorly going onto the septal floor, some sort of an extended endoscopic, extended Haddad flap. And anteriorly we came all the way along till the mucocutaneous junction. We thought because you have to go into the anterior skull base, it's better to have as much flap that you can have. Now this we would not have done if there was disease at the septum anywhere in the roof on this side. We definitely would not have done this Haddad flap. So Haddad flap, you'll have to see as to, it has to be on the case-to-case basis. It cannot be done in all cases. This is one case where it was possible. Majority of the times this will not be possible. Let me tell you that. So majority of the times you will not be able to use the Haddad flap in a malignancy. Again, let me stress on that fact. In a case of a malignancy. Otherwise, for pituitary surgeries, routinely you would do a flap. That's a different thing for benign lesions. So here, we just raise the Hadad flap posterior, we just posteriorly from the anterior wall of the sphenoid here, and then we are just putting this Hadad flap into the nasopharyngeal area away from your area of resection. So once that is done, we went ahead doing the ethmoidectomy on the opposite, the right side. That is the area where there was disease, and so in this case, we did the septectomy in the beginning itself. So in the beginning itself, so it could be done this way as well. So we removed the septum and we made way, because it was a S-shaped deviation. So we made way. So we removed the entire septum on either side. This is the Hadad flap here, and this is the choana here, as you can see here on either side. And this is the anterior part of the nasal septum. We just removed it for better clearance. So we debulked the tumor as much as we could. Then we we just doing an uncinectomy and antrostomy on the side of the disease and clearing the disease as much as possible here. So we just are doing an ethmoidectomy here with the debrider and just clear the disease off it. So most of the disease was on the, so that's the Onodi cell that's just seen superiorly. That's the sphenoid sinus that just opened up. That was superior to the sphenoid sinus. You can see the opticokeratico recess here, the optic nerve superiorly. And then we're just removing the, you can see the sphenoid palatine artery. That's right. So that's the artery there. So yeah, that's exactly the artery that is based on which you raise the Hadad flap. That has to be coagulated properly. Now once that is done, now here I'm trying to so posterior extent is done. Sphenoid sinus is seen. Now we are trying to look at the frontal recess. So I'm just trying to remove the mucosa at the frontal process of the similar to the Omol's axillary flap, but in this case it didn't make a flap. I removed that mucosa so that to make the access better. You see the frontal sinus seen well. Now you need to widen this frontal recess much more than this, and similarly on the other side, so that the entire modified Lothrop's draft 3 procedure can be done. So posteriorly, you will see the ethmoidal artery. We will see that. Now I'm just doing a uncinectomy on the opposite side. That is on the left side. We now did the uncinectomy, ethmoidectomy, and the sphenoid opening on the right side, doing the similar procedure on the left side now. And in the process, the tumor was debulked. So here we're just doing an ethmoidectomy, and then we'll be opening up the sphenoid now, and then the antrostomy would be done. So yeah, so they have to be careful here because you want to protect the Hadad flap, which is here inferiorly. So that's the sphenoid sinus, and that's the planum area. This is the entire cribriform area here. So this is the lamina papyracea here, lamina papyracea on that side, right? So you can see here the lamina papyracea on this side and the lamina papyracea on that side. So we just drill the entire tumor on this side has been debulked. So whatever tumor is left is only left on this. That is the basic area of attachment of the tumor. There you go. So these are the ethmoidal cells. So here we are just doing an antrostomy. Yeah. Now the frontal recess on the opposite side is also being opened, and now we have done a Lothrop. So this is the frontal beak area. We're just drilling it to see that. So that is the posterior wall of the frontal sinus. This is the frontal beak anteriorly. That's the posterior ethmoidal artery. You need to cauterize that pretty well there. And we'll see the anterior ethmoidal artery also. There you see the anterior ethmoidal artery, which we are cauterizing again. That's the anterior ethmoidal artery. This is the anterior ethmoidal artery on the other side. So you need to cauterize them on both sides before you go ahead with your procedure here. So once you have done that, now you can just drill away this. The disease is only here on this area. The rest of the areas it has been debulked. Now this cribriform area, this disease initially was there only on the right side. Just to make sure that there is this disease there, we are just sending that bit for frozen and confirm that is disease before proceeding with the opening up before opening the dura. So you just have to drill this bit till you thin out the bone as much as possible. this has to be drilled adequately well, and then the crista galli also will has to be removed properly. Otherwise, reconstructing it will be a problem. So that's the planum area where we're drilling. And here you'll have, as you're dealing with the olfactory fibrils, you'll have some amount of CSF leak. You drill and then you expose the dura all around here, as you see. And at this point, you're doing a four-handed technique. You're not doing it, with one hand. It has to be a forehand, and you have your neurosurgeon as well with you. So I definitely have a neurosurgeon with me at this time. And here we are just dealing. That's the fox cerebri area, the fox of the dura there. So that needs to be slowly dissected out. You'll have arteries, which is in the base there, that needs to be protected. The olfactory bulb was removed on the ipsilateral side. Now the disease was removed here. And now we are seeing the edges of the dura, which is sent for frozen, and it was negative, and that's when we started reconstructing. So we do it in 2 layers. This layer is tucked in above the dura all around, like this, and we use the tissel to just improve the seal that you get. And you should get this pulsation. If you don't get this pulsation, that means you're not achieved the yield. And then on top of that, you put another layer of fascia, and then this fascia should not block the frontal sinus. It should go and drape the posterior wall of the frontal sinus. Otherwise, there will be, the patient may develop a frontal mucocele. So the Hadad flap is put there, and you, pack it well with, gel foams, and we definitely do put the Merosul pack for about at least 72 hours, and then remove the Merosul pack. So this is a combined CFR. This is open with endoscopic. So this was an extensive disease, a young 29-year-old male presenting with a nasal obstruction, and with a headache and giddiness. There was a nasal mass which was biopsied, and it was a sinonasal neuroendocrine carcinoma. So you can see there's a significant intracanal extension. It is going almost, it's going beyond the medial edge of the orbit here. So even after NACT, you definitely would not want to do it totally endoscopically. It has to be a combined approach. There's significant intracanal extension here. So the patient received 2 cycles of NACT, and it's a cisplatin etoposide base, and then there was a partial response. This is a post NACT scan. You see there's a significant response, but there's considerable tumor that is still there. But we decided, based on the pre-NACT kind of a disease, that we'll do a combined approach. And also there was disease close to the medial rectus on this case. So we just wanted to do an open procedure. So that's the team. And so we first started with the from above, and because to have a better control, because of the significant intracranial extent of disease that was there in the pre-NACT scan. So we raised the pericranial flap for we decided that we'll use the pericranial flap for reconstructing the defect. So with a bicoronal incision was used, and then we raised the pericranial flap, and then that's the pericranial flap that was raised. We went posteriorly as much as we could, and then we did a bifrontal craniotomy. So it's very essential to go laterally from the pterions and come here, because otherwise you'll not be able to do a proper craniotomy. So once the craniotomy is done, it's very essential to safely keep the bone in a sterile solution, because it has to be used with plates and screws subsequently. And here again, when you're using this instrument, if you have to dissect, once you've done the burr hole, you have to dissect the dura away, so that as you're coming with this, you don't excise the entire dura there. So that can happen. but then you have to be careful. In this case, it has not happened. So we have removed the posterior wall here, and then we are dissecting the dura from the cribriform area here. Extradural dissection is being done superiorly. This is done under the microscope here. This is the picture of the microscope. So at some point it will become a bit blurred. That's the area of the disease there. There you can start seeing the disease there here. You can, and you just there inferiorly, we're just incising the dura. As you can see some amount of disease coming intracranially there. So since there's disease seen there, we are going beyond for a margin and resecting the dura beyond the disease that is seen. So the disease is more on the left side compared to the right. So, and then we are going and dissecting on the right side, and then here you'll have the sagittal sinus coming. So most our neurosurgeons, they ligate the sagittal sinus here, and that is, you can see that being bipolar, and they're just cutting it after ligature, and then that will be removed inferiorly, dissected away from the normal parenchyma. So there's no disease there. That's the normal parenchyma that is seen. That's not the disease. So we're just making sure there's no disease, and we're removing some part of the frontal lobe. We know that we can remove some part of the frontal lobe without causing much neurological deficit. So intracranial portion of the tumor is being removed. It's just slowly being dissected away with some away of the parenchyma that is there. You can see there's not much of retraction that is being done on the frontal lobes. So that is very essential again to minimize the post-op complications. There you see, then once that is suctioned out, you see the normal white parenchyma that is there. So that's exactly the way the neurosurgeons function. They just do the suctioning and then just get it out, bipolar, suction it out. And this is the lateral margin on the dura on the right side. They're just dissecting it out and incising the dura there and getting it out. That's the dura is being excised laterally there. And the posterior aspect of the dura is being excised here, looking at having direct control on the tumor. So that it's at the dura now. The part of the parenchyma has been resected as well. The dura laterally has been resected here, laterally, posteriorly, and this laterally again has already been excised, and we have excised extradurally from here as well. So you can see that excision of the dura, and then yeah, you can see that that's the dura closer to the planum here, but we are slightly away from the planum. Yeah, the dura is again being resected here, and that's being connected with the posterior extent here. So once that is done, then we are going intranasally. We stop there, and then we go and do the intranasal part. That is the tumor that is being debulked, without damaging the adjacent normal mucosa. This, you can see this septum is free anyways, but it's more so arising from the vault and the nasal wall on the left side. So we're just debulking the tumor here. It's post NACT, so it's very oozy. It was the case in the previous video as well. So kindly bear with me for that. So we're just debulking the tumor to just see where exactly it is originating from, to look at the landmarks here, because essentially you can appreciate that there's no landmark that is being seen here, you know. So we're not just debulking the tumors. You can see the Onodi cell here as we go posteriorly. And then we're just trying to remove all the tumor, debulk it, so that the tumor can be removed superiorly with whatever has been cleared so far. That will be seen in a while. So that's the sphenoid sinus here. The sphenoid mucosa has been removed fully there. That's the sphenoid sinus. You can see now things are better. That's the ONOD cell with the optic nerve being so bare that you can just appreciate this. So if you're not aware of this, we would go and damage the optic nerve. Now there, the tumor that was already being, dissected and already kept ready, we have debulked it and kept it ready for it to be delivered from above. So the tumor will be, and this is attached to the septum as well. So we have resected it from the septum superiorly, and we'll get all the margins cleared as well. And the tumor will be delivered intracranially. Now, as you see there, sorry, it's a very bloody field there, but I couldn't help, but that's how it is. So yeah, now as it was above, this is another view. The tumor, as we just released it from inferiorly, the tumor is being delivered from above. There you go. The tumor is out there, and the margins will be got henceforth. Now superiorly we have got margins on the dura and everything else. So now we need to get the margins from the intranasal part. So now we are removing the septum here. I'll just slowly just make it fast forward it. We are removing the mucosa. That will be the anterior margin. So we have removed part of the mucosa. We are removing the septum here, right? So, and then we're doing the ethmoidectomy on the opposite side. So septum has been totally removed. That's the ethmoidectomy on the opposite side, right? So this is the antrostomy on the left side now. Now this disease here, which we see, it's adherent to the lamina papillaris eroded. It's close to the fat here. So we are just debulking the disease, and then you'll see what's being happened. That's the edge of the bone there. Okay. That's the superior orbital. Yeah, that's the base of the skull there. And that's disease that is close to the bone there. We're just drilling away the bone. Frontal beak area there. So when you have to remove the fat, you don't want to do it to begin with itself, because the fat will prolapse and it will be an hindrance. So you can see it is the fat is popping out. So I just stopped there, went and did the clearance elsewhere, and towards the end you will see that I'll be removing the fat for the disease clearance subsequently. Because if the fat props out like this, if it is more than this, then it will be very troublesome to handle that. So we now incise the mucosa here, the periorbita here, remove that along with the fat, because if this comes free, the fat and is free of disease, then we don't have to do an exenteration for this gentleman. There you go. So now we're just drilling the ledge of the bone all along, and now the dura is being repaired with the fascia, the tensor fascia lata. That is the first layer to achieve the seal. That is being repaired all around. So that seal is being achieved to begin with, and then the second layer will be formed by the pericranial flap. Yeah. So we're just trying to get that ledge of the mucosa for suturing the pericranial flap there. You see the pulsation that is there. Once you achieve a good seal, you'll naturally start getting that pulsation. So now the pericranial flap is being put down there, and that will be sutured to the edge of the dura posteriorly. So that you can understand now, if you resect the dura way too posteriorly at the planum area, then it becomes that much more difficult to get this suture. You will not be able to get that seal. That is why we don't consider upfront surgery for that. That becomes one of the indications for considering the patient for neoadjuvant chemotherapy as well, and definitely not for an endoscopic procedure. So you take a couple of sutures around that area, and so once that is done, that's when we decided to remove the fat. In the meantime, that it was sent for frozen, and there was disease, but we just wanted to confirm. You'll see the medial rectus muscle coming into view there. You see the rectus muscle there. So we inked this surface and sent, and that was negative, and then so we stopped right there. We didn't go beyond this. So that's the medial rectus there. So that was inked and sent for frozen. So once that is free, and this patient definitely goes for adjuvant chemoradiotherapy for more than one reason. One, it is a high-grade cyanonasal neuroendocrine carcinoma. It's post NACT. Though we could achieve negative margin, we still would send him for chemoradiotherapy. Now, this is the other layer from intranasal aspect. So this forms third layer, which we will put in addition to the two layers that have already been put here. And again, you'll see the pulsation that you'll get as we just put the layer, and then we pack it with gel foam adequately, and the beneficial pack will be kept for at least 72 hours before we remove it subsequently. And there you go. The the fascia is being put all along, and it will be packed with fascia, with gel foam. So no nasoseptal flap, nothing is possible. You see the pulsation there. It's a good seal that has been achieved. And this patient went on to receive adjuvant radiotherapy, and all margins were free. That was sent. And so he's finished his treatment. He's on follow-up right now. And that's the end of this. We can take questions so far.
The next question is by Dr. Vijayadharan, sir.
Yeah.
So he was asking your thoughts on using fat graft to obliterate the dead space during endoscopic recession, especially when the patient might go for the adjuvant radiation.
But the fat is not going to help in any ways because it's a avascular amount of fat. So we usually don't put fat. We just put some amount of gel foam there, because the other problem is the fat might be a source of infection as well. Subsequently, it's an avascular material there. So that's why we choose to put a pericranial flap. Though the tensor fasciae lata is again avascular, that is sutured to the dura, which forms a good layer scaffold for the healing to happen. And the pericranial flap is more or less vascular, which takes care of it. So we don't want to add some amount of fat there, which again might add as a source of infection and may not help much. Some people do put fat, but it's for a smaller defect. But we, as a practice, we don't put fat for the defect.
Okay, sir. So next question is by Dr. Satyanarayana Chaudhary. Do you use any navigation system, and what do you mean by the better CCD cameras?
There's a 3D and 4D systems that are available as of now. I'm not sure if it is Olympus or Karl Stoes. We recently happened to come across one. I think it was Karl Stoes. So it gives you a good vision and a color differentiation. So that helps in your surgery. And that's what the CCD, the camera and the monitor, both of them are different compared to the usual ones that we would use. What is the other question? Sorry, I didn't get it.
I think he is asking about different kinds of cameras, CMOS or 3-chip.
Yeah, the minimum will be a 3-chip camera. That's what we would use.
Oh.
So this is beyond that.
Oh. So in case of next question is by Dr. Vivek. In case of carotid sacrifice or engulfment of carotid, what is the role of carotid sacrifice or bypass?
So in skull-based malignancy, if there is a need to sacrifice carotid, that's not the case for surgery, because in anterior skull-based surgery, at least if the lesion is in the anterior skull-base and going posterior towards the sphenoid, that is not a case for a surgical excision. So we would use a non-surgical treatment option if at all for that patient. If it's a benign lesion, that's totally different. But for a malignant lesion encasing the carotid, it's not a surgical candidate. Because mostly there'll be high-grade lesions, and sacrificing a carotid, adding to the morbidity, will not help the patient's cause. He's a non-surgical candidate.
The next question is by Dr. Abdul. In case a patient receives NACT and he becomes operable now following NACT, what do you do about decide on margins? How do you decide on margins?
So we definitely look at the pre-NACT pictures, but then we would not go with that margin. We'll go with the existing margin, but our approach will be based on the pre-NACT disease, because we don't want to be caught by any surprise. Like for example, based on this case, you saw the
Okay.
pre-NACT, post-NACT. Post-NACT looked tempting to do it with your completely endoscopic approach, but we decided against it because it was closer to the medial rectus and it was just at the medial edge of the orbital wall. And pre-NACT, there was significant intracameral extension. So we upfront decided, even if it is a good response, we will do an open surgery.
Okay, sir. One of the youngsters in our audience is asking if there is a skull-based course in TMH.
Yeah, there is a 2-year, there's a 1-year fellowship in Tata Memorial Hospital. It's been there for quite some time now.
Okay. So next question is a good one. Sir, whether if the outcomes of both orbital exentation and the preservation are coming to be same. So in case of orbital apex involvement, what should we do?
Orbital apex involvement, it's again, you have to take a call whether you'll have, what is the histology? That's the first thing you need to look at. If it is a
Okay.
high grade histology, adenocystic carcinoma, you can still be a bit easy. But if it is a high grade carcinoma, if you cannot get a negative margin at the apex, you are less likely to get a negative margin. And all studies have shown that if you don't get a negative margin, it's detrimental for the patient. 1. 2, it doesn't impair survival whether you exenterate or even if some amount of positive, with the positive margin you save the orbit. But the thing is, you should protect, the patient will receive adjuvant RT. Though with whatever technology we have, the complications due to the adjuvant treatment to the orbit could be significant. So that might be again detrimental. But then the first thing is to get a negative margin, whatever at whatever cost if possible. If you cannot get a negative margin, all the studies have shown that the outcomes are detrimental.
Okay. Sir, one more question from Dr. Ratan Shetty is that in any role of debulking surgery for skull-based tumors? I think he meant to be in case of palliative.
No, there is no role just to debulk the tumor and do it. I don't think so. There is a role. If you should go in for the surgery only if you can, if you think you can get a negative margin. Adenocystic carcinoma is one place where you may go with an R1 resection because it's not the patient may still survive with some amount of disease. Your adjuvant RT will control the disease for some time. And even with lung metastasis, patients with adenocystic carcinoma tend to live for 3 to 4 years without much symptoms. So that is the only case in a malignancy of the skull base where I would not, I would go with an R1 resection. But otherwise, rest of it, I would want to get an R0 resection.
And one of the juniors who are again asking is, please enumerate all the contraindication for the surgery.
Contraindication is simple. First thing is any involvement of the facial bones, the frontal bone, the nasal bone, involvement of the skin, gross intracranial extension, and disease extending lateral to the medial orbital wall. So these are all contraindications for a complete endoscopic procedure. It has to be a combined procedure. It has to be open plus endoscopic. And sometimes only open.
Okay, sir. Just last question, I think, sir, from Dr. Ravi Roy. Do we need to suture the flap to the dura in case of craniofacial resection? Whatever the endoscopic resection?
No, we don't suture. Endoscopic. In endoscopic, we don't suture the flap. We just tuck in the flaps adequately well to get a seal, and then we use the fibrin glue to add to that, and then we put a second layer and pack it with gel foam. And post-operatively, you take care. You ask the patient to have a bed rest for 2 days, give laxative, antitussives, and remove the pack after 72 hours. And take all precautions. And we don't use upfront lumbar drain. There is no indication to use upfront lumbar drain. It's a problem when you use a lumbar drain. It'll give rise to infections, meningitis due to the lumbar drain if you don't handle it well. So we, as an institute, don't use a lumbar drain. There are some people who may use it, but we don't.
Just last question, sir, from Dr. Rai. I think is piecemeal resection, how can we precisely orient for margin?
No, the margin is not for the piecemeal. Now you remove that, and then if like in this last video that we saw, we needed to give a margin of the fat on the orbit. We needed to give the anterior margin on the septum, the posterior margin on the nasopharyngeal mucosa. The lateral margin is a nasal mucosa on the opposite side. So that's why it's important to map, as you will give multiple specimens in all of these patients. You'll have some 20-25 specimens, and then you need to in an OT notes say as to what are the margins. So at the farthest more end, you need to, that's why you need to plan where the tumor extent is. So it's probably attached to one or two areas. In this case, you saw it was attached to the septum superiorly and the vault, that is the cribriform area, and then the lamina papyracea. So we needed to go anterior, posterior, and lateral to it.
Okay, sir. So next question by Dr. Sriharsha, sir. At what time do you take the post-op scan?
So as a protocol, we do when we do a craniofacial resection, we do it in the first post-op day to begin with. If the patient, to rule out a pneumocephalus, that's the institute protocol. Especially when you do an open procedure, or even if you do a craniofacial resection, because there's some amount of air that is going in as you do the procedure. And we do it in the first post-op day, and then we don't repeat it if the patient clinically does not deteriorate, does not show any symptoms or signs. And subsequently, if the patient shows any signs or symptoms, which is worrisome, if the patient shows any signs of meningism, if the orientation deteriorates, then we would repeat the scan at that particular point. But first post-op day, and then based on the clinical features subsequently.
So next question is by Dr. Jamal. In last case, the combined approach with the reconstruction with the pericranial flap, how to prevent the CSF leak in frontal head and frontal sinus, I think, through the frontal.
Yeah. So that's why it's anyway, first layer is a fascia lata that is being sutured to the dura. Second is the pericranial flap covers it seals off the frontal sinus from the dura. That's the second layer. And then the third layer again seals it further. So it is obviously sealed from that area. So posterior wall is drilled out. No. Anyways, at least in this case it was. You don't have to do it always, but if the posterior wall is intact, then that's not a problem at all.